Hey, hello, everybody. Welcome to our Digital Scholar webinar. This is hosted by the Southern California Clinical and Translational Science Institute, the University of Southern California, and Children's Hospital, LA. My name is Eric Peterson. I'm the co-director of digital recruitment and scholarship here in the SCCTSI. I'm also an associate professor of psychiatry and behavioral sciences here at USC. So for our webinar today, we're really excited to have our speaker. She does have some questions throughout that you can use the chat function to communicate with her, but also we ask that you just put your questions into the Q&A feature or into the chat feature as well. I will facilitate a discussion at the end, so type in your questions as they come up, and then we'll have a discussion at the end. I can read the questions aloud. So we're very excited today to have Jacqueline Penn. She's going to be talking about word frequencies and how they reveal racial differences in clinical documentation. This is a talk that one of our members of the CTSI saw and begged us to have Jacqueline come on and redo this talk. So we're really glad to have her present today and thankful to all of you for attending. So Jacqueline Penn is a third-year medical student at Thomas Jefferson University in Philadelphia. So it's about 3 o'clock for her out there. So we appreciate her taking the time this afternoon. It's just about noon lunchtime for us here in California. But before entering medicine, she earned a BA in economics and spent 3 years working for the Federal Reserve System in macrofinance and macro international research. So she's got a lot of really great skills. She's an excellent presenter, and we're really fortunate to have her. And so I'm going to turn it over to Jacqueline now.
Okay, yeah, I don't need to introduce myself. That was a great introduction. Thank you. So just on to disclosures. I have none. So learning objectives for this session. One, to understand the potential for using computational tools to study racial bias in large clinical corpora, and 2, understand some of the challenges to providing a nuanced analysis of bias in clinical documentation. So just some background. We know that racial inequities in health exist, and some of this is due to structural factors like income inequality, as well as individual biases. So in this paper, we wanted to ask, how are racial inequities in healthcare reflected in the clinical documentation? And by clinical documentation, we are specifically focusing on the notes. We're not the first people to look at this. Previous studies have identified differences in note language by patient race, but this tended to be a hand analyses of relatively small numbers of notes, like 600 or so. Thus, we wanted to also ask, what role can informatics technologies play in identifying mechanisms of inequity in large data sets? And this is important because if we could easily apply computational tools to large data sets to identify bias in clinical notes, this could allow departments or institutions to use such tools to monitor bias internally, which would ideally allow for prompt intervention to address any problems. Additionally, identifying specific mechanisms of bias in clinical notes could shape medical education. If trainees like me and practicing clinicians are aware of how bias looks in the notes and are taught to minimize the bias that occurs when writing the notes, then those who read the notes are less likely to form negative impressions of patients based on previous providers' attitudes. And this could overall lead to better patient care, since previous work has shown that bias does impact clinical decision-making. So just to make this clearer with a picture, you have the patient encounter, provider and patient meet each other, and then the provider writes a note about that encounter. And then later on in the future, the next provider will read that previous provider's note and is influenced by what that note says. So being aware of this sequence of events, this study wanted to look at the role of bias at the level of the note. And we really just limited our analysis to just looking at the notes here. So we had hypotheses, and our main hypothesis was that we would observe differences in both note style and note content by patient race, and this would reflect interpersonal and systemic elements of racism, respectively. So more specifically, in terms of note style, we hypothesized that compared to notes for white patients, that notes for Black patients would have more negative emotional tone, greater use of anxiety and anger language, as well as more social dominance language. So that relationship between provider and patient and the social interaction at play there. And then in terms of note content, we hypothesized that there would be significant differences in the mentions of opioid pain medication between Black and white patients. And this was based off of previous literature that showed that the pain of Black patients is often underestimated and undertreated. So what data did we use? We used the MIMIC3 data set, and this is a public use de-identified data set that contains data from Beth Israel Deaconess Medical Center from 2001 to 2012. It has data on all the ICU admissions during that time. So it has information on what happened in the admission. It has information on the patients and their demographics, as well as contains data that has the note text, which was very important for this study. So our analysis was based on comparing racially paired cohorts. So how did we do this? We first stratified based on race. So we only focused on white and Black race here for a couple of reasons. One, the data set is heavily skewed white. So there weren't that many patients in the sample that were not Black or white. Second, different races have different stereotypes associated with them. And so we just wanted to focus on pro-white, anti-Black bias. We also stratified based on gender. So the data only has male and female binary gender. So that's what we used. And then we also stratified based on diagnosis. We had wanted to look at a lot of diagnoses, but for the sake of sample size, we just focused on the two most common, septicemia or sepsis and atherosclerosis. And these were selected because they were the two most frequent primary diagnoses listed in the data set. So patients can have multiple diagnoses for an admission, and this was the primary one. We wanted to do age groups, but the sample size, even though it's a big sample, wasn't quite big enough to do that and still maintain adequate number of notes in our smallest groups. So how we ended up controlling for age was that we just restricted to patients age 50 and above, which allowed us to focus on a relatively older population, while also removing some of the patients in the sample who are just very, very different, like neonates. And we kept all of the note types. So in this table here on the right, you can see the different types of notes we included. We didn't make any cuts. We only dropped notes that were flagged as being made in error. Okay, so the first thing we did, and this is not in my AMIA presentation, was an exploratory vocabulary analysis. So to do this, we first took the note text and tokenized it using spaCy. So that allowed us to extract all the individual words. And then we calculated the relative differences in word frequencies between cohorts. So we calculated the mentions per admission. And then we just did a manual browse of seeing like what words have the biggest difference in relative frequency between these racially paired cohorts. So these are some of the words that stood out in that initial exploratory analysis that may reflect bias. So rude, belligerent, uncooperative, and aggressive. you can see that the difference is quite striking. So here, when we were looking at rude, there were 36 mentions of the word rude across 81 admissions in the Black male septicemia cohort, whereas in the white male septicemia cohort, you only had one mention of the word rude across 712 admissions. So this is the most dramatic example of the difference in frequencies, but these other words had notable differences as well. But then we wanted to move beyond looking at individual words. So we wanted to look at categories of words. So in order to address our hypotheses regarding emotional language and social dominance language in the notes, we utilized this LIWC, Linguistic Inquiry and Word Count software. This is a commonly used tool in the social sciences that's used to analyze the frequency of various word categories in text you input into it. So it has 70 categories in total. We didn't use all of them, and it outputs the results as percentage of each note that falls into each given category. So this allowed us to quantify the degree to which certain categories of words were represented in our cohort's notes. Specifically, we looked at categories that reflected general emotion, so emotional tone overall, as well as positive and negative emotions separately. And then we also looked at anxiety and anger language, which we picked based on previous studies that had looked at this, and racial differences in note language. And then the third thing we looked at was the social dominance language. So we had two variables, or two categories that we were looking at that represented social dominance. The first was this power category, and we picked this based off of the LIWC manual. It had a description of what the category was supposed to represent, and to us, it sounded very much like it would represent social dominance. And then the second thing was first person plural pronouns, so we, us, our, and this had been looked at in previous literature and used as a shown to be representative of social dominance language. So before getting into our statistical analysis, I just want to show some initial graphs to show some high level differences. In these graphs, you can see that for each LIWC category and cohort, the percentage of notes that contained a word in that category. Sorry, yeah, let me say that again. These graphs are showing what percentage of notes contained a token or a word that fell into this category. So you can see that certain categories had almost every note had a word in that category, whereas other categories were much less common. And you can also see that even just at this level, there are some differences in race with the frequency, but it's not always in the same direction. So here with anxiety, you can see that's a drop down versus a drop up. So this is not statistical analysis here. This is just an overview. So let me show you some representative results from our statistical analysis. The full table of everything that we looked at and all the tests that we ran is in our paper. But these are just some representative results. So overall, we found that notes for Black patients tended to have more negative emotional tone and greater use of social dominance language than notes for white patients. And so the left is supposed to represent the emotional analysis. So this variable, emotional tone, is actually the only LIWC category that we looked at that doesn't report as percentage of note. It combines a lot of different categories and is a non-transparent variable. So we don't know how exactly it was calculated, but it's an overall measure of the emotional tone of the note, with 0 being 100% negative, 100 being 100% positive and 50 being neutral in tone. You can see that across all cohorts, the tone for the notes is overall negative because we are between 0 and 50, but that the notes for Black patients are notably more negative in tone. And then in terms of power, which was one of our social dominance measures, we can see that the note frequency overall is not very high, but there's still notable differences in the frequency between the Black and white notes, with greater use of the social dominance language in the notes for Black patients. So that was our note style analysis, and now on to our note content analysis. So for analysis of note content, we ended up looking so how we did this is that we first applied this program Apache CTAKes to the notes, and this tags UMLS, Unified Medical Language System, defined concepts in the notes. And then using the CTAKes output in addition to information from the clinical decision-making tool UpToDate, this allowed us to tag the opioid mentions in the notes. And here's a graph showing the overall results of this. Again, there's no statistical points made here, but overall you can see that for most of the groupings, there are more mentions of opioids in the white cohorts compared to the Black cohorts, which is consistent with our hypothesis. The exception is this group over here. But this doesn't do statistical analysis. So in order to test this statistically, we ran the logistic regression over here. So on the left, we have an indicator for whether the note contained an opioid mention or not. And then on the right-hand side, we have the patient factors, so race, gender, and diagnosis. And from this, we found that the notes for Black patients were about 30% less likely to mention an opioid compared to notes for white patients. And that was significant at the 1% level. So just to recap, we found significant differences in note style and note content by patient race. In terms of note style, the notes for Black patients had more negative emotional tone and more social dominance language, and the notes for Black patients are less likely to mention opioids in terms of our content analysis. But the big question is this a reflection of bias, or is this something else? So for the opioid analysis, previous work had shown that Black patients' pain is undertreated and underestimated and undertreated. And there are many reasons for this. Some could be that the persistence of medical myths. So relatively recent studies have shown that there's still a lot of trainees and doctors who believe myths like Black patient skin is thicker than white patients, that Black patients have less sensitive nerve endings, or that they just don't feel pain the way that white patients do. All of that is totally false, but there are still providers who believe that. So maybe these results are a reflection of that. Alternatively, it could just be that at the time this data was being collected, the opioid crisis was largely affecting white patients. So there are ways that we could go about distinguishing, what is the case here with this data. We didn't do that yet, but maybe we can talk about that in the discussion if you guys are interested. But what we did dig a little bit more into is the emotional tone and social dominance results. So why are we seeing these differences? We ended up doing a little bit of hand analysis to find out. So LIWC, the way it works is that it has, for each category, it has a library of words that it's trying to match to words in the note text you put in. So we reviewed what words was it tagging in each category. So we found that for a lot of categories, this program was unable to differentiate between clinical language and words that may reflect bias. So in the negative emotion category, the top tagged words included pain, failure, low, lower, and shock. And in the power category, which was supposed to be representative of social dominance, top tagged words included failure, status, up, low, and doctor. And yes, these words could be reflective of negative emotion and social dominance, but when you know that the text came from clinical notes, it's very obvious that it's likely that these are not referring to any kind of emotion or attitude, but instead healthcare language. So if you recall, the diagnoses we were looking at were septicemia and atherosclerosis. So septic shock and cardiogenic shock happen in the ICU all the time. So it's much more likely that that is the shock that is being talked about compared to emotional shock. And doctor, obviously, healthcare language. Okay, so this is like the interactive portion. I'm going to open the chat, and I would encourage people to put in a word that they can think of that could be a negative sentiment word that could reflect bias, or also be a healthcare word. And if nothing comes to mind, then feel free to, feel free to pick one of these and talk about how might it be used in both contexts? Oh yeah, complained of. Yes, dirty, clean. Okay, yeah. So those are good ones. There's a lot of, so this like complained of reminds me of a discussion about using the word denied. Patient denied alcohol use. Very, very standard in medical language, but has a very different connotation when read by an outside healthcare person. Okay, cool. Okay, so I'm going to move on to the next thing I wanted to talk about, which is our vocabulary analysis. So I already talked about how we dug a little deeper into the LIWC analysis, the categories of words analysis, talked about how we didn't really do any additional analysis with the opioids, but that could be something for future work. We did end up doing also a little bit of hand analysis related to our exploratory vocabulary analysis. So recall that the words that we were looking at that stood out as possible bias language were rude, belligerent, uncooperative, and aggressive. So what we ended up doing was we just looked at the use of the word rude in the notes and saw how it was being used in context. So, and what we found out was that it's not always a reflection of provider attitude. So yes, we did find the word rude used as a reflection of provider attitude in this first thing. Patient has been rude and stubborn. He wants things when he wants them, doesn't wait to get out of bed, doesn't do what he's told. But we also found that it could be a description of a non-patient. So here it's a description of the patient's son or somebody's son. Also, we found the word being used to report what somebody else said. So here it's the floor nurse reported that the patient was rude. It's not necessarily the person writing the note that thinks that. And we also saw it used to describe a health state that has some mental or emotional components. So here you can see at times he can be rude with nurses. It's probably a combination of uremic or hepatic encephalopathy in the setting of sepsis. So it's not likely that the person writing this note has a negative attitude towards this patient. They seem to really be acknowledging that the behavior is a product of their biological condition. And then the last thing that was very striking was, at least for the case of this word rude, the influence of copying and pasting sections of notes was quite dramatic. So almost all, if not all of the occurrences of the word rude in the black male septicemia cohort was the result of a single sentence that was copied and pasted across a lot of notes. And aggressive and rude had the same number of counts in that initial analysis because they are together here in this single sentence. So that's something definitely to keep in mind for future work and limitations of this work. Okay. It's a little bit non-traditional, but I'm going to talk about the implications and conclusions. And then after that, I think we're going to have a little discussion about limitations because I was hoping that would be interactive. So overall, applying computational analysis is a fast way to analyze large data sets of clinical notes, but it also presents challenges regarding the context of those words and as well as miscategorization. Thus, more nuanced methods of analysis should be developed for analyzing bias in large data sets. And one way to do this could be integrating qualitative methods. So in this study, we did that twice. We did it with our LIWC word category analysis. And then we also did it with our exploratory vocabulary analysis. And that hand analysis really gave us context to what we were doing and completely changed how we went about this paper. Really, this would have been a completely different type of thing had we not done that little bit of qualitative analysis to accompany the quantitative. Alternatively, you could take a more technology-focused approach and develop an LIWC-like tool that categorizes words, but it's more specifically tailored to healthcare clinical language. So it wouldn't be accidentally tagging obviously healthcare words as emotional in tone. And okay, that's it for the majority of my presentation. I thought this next bit could be a little interactive. And I encourage people in the chat to name a limitation of the study and how it could be addressed in future work. Or if you just want to shout out one of those things, you know, something you think could be improved upon, or suggestions for how you might further this analysis.
I just have a lot of questions about, not a lot, but some questions about this, you know, qualitative component that you did. Mm-hmm. I mean, you'll probably talk about it a little bit more, but just, I mean, what is the lift for that? What is the burden like to go, you know, sort through all these notes to actually then look specifically at, you know, the context of the words, and how much of that were you guys actually able to do?
Oh, so yeah, we did very minimal qualitative work. There were only a handful of notes that mentioned the word rude. Like we had a very focused, like what we were going to look at, just to see, you know, what kind of stuff are we dealing with. And then in terms of, so that maybe, I don't know, that was done in a day or less of just me working. And then in terms of the LIWC stuff, looking at what words were like the top tagged words, that I mean, I guess that wouldn't even necessarily be like qualitative, but that I could just do in Stata. So that was not very difficult. It just was kind of what little extra steps could we do to gain some more context here. That being said, I have done brutal chart reviews for other research projects, and I think you know, depending on what you're trying to look at, you could try and make it really targeted and brief, depending on your resources. Or if you have a medical student that has not endless time, but is willing to work for free for a summer, that's something that they could do.
That's great. Yeah. So if anybody else has anything that they want to share in the chat, I'll just throw out one more there about, you know, so a lot of the research that I do is in addictions. So, you know, thinking about one, it's at, you know, one medical center, I think in Boston, right? And then it's in the ICU, and just really be interesting to see what this would look like in like, the mental health clinics.
Yeah. So, oh, we got a comment. Okay, limit of population the study addressed. Excellent. Would be yes, young adults, different types of patients. Yes, many other populations. Excellent. So that was the first in the limitations that I was going to talk about for this paper. It's Boston, which is very, very white city. And arguably not that diverse. But yeah, there was a major racial skew. So this was limiting because had we had a city that was more like not so white, then we could have had larger cohort sizes, because if you saw in my like cohort design slide, the white cohorts were so much bigger than their paired Black cohorts. So this limited how many things we could control for. Like we wanted to control for insurance status, things that were in the data, or age, more refined age cohorts, or even look at maybe like alternate diagnoses like primary and secondary or something. But yeah, the sample was pretty limiting. So would love to get hands on another data set. I know that there were some talks with my mentor about, could we get a hold of like PITS data or different medical centers data? No updates on that yet, but that could be a direction that you go with this, like try and reproduce it in a different, more complete or more diverse data set. The other thing that was huge was the missing note writer demographics. So previous work has shown that it is important what race, what gender, what training level the provider is in, what degree of bias is present, and how that influences the interaction. We didn't have anything on provider gender or race. There was a little bit of, there was one variable that had some kind of like training level in it, but it was so sparsely populated and not reliable looking. Let's see what somebody put in the chat. I wonder how content of and language used in the notes are being impacted by the fact that, yes. So I think that I'm 99% sure that this was all pre-Open Notes, because it ended at 2012, and I think Open Notes is like a very recent thing. But yeah, I wonder that too, because even from the clinical side, I've only been in the clinical space now for this is my third week working with patients and providers in the clinic, and there are things where we talk about, what do we think is going on with the patient, and then somebody thinks, but should we put that in the note? Like, is it important enough? Because the patient might be upset, or the family member might be upset if they read it. And that's definitely influencing things. And I think that's a great point. The last limitation, which I already mentioned, is the copying and pasting of no text. We don't really know the degree to which this has influenced our analysis or other analyses that use, the note text of Mimic 3. I know that there is at least one proposed method that has been published in some form. It might be a preprint paper about how you might be able to correct for this, like using the computer. It's beyond my technical level. But looking to address that could be something for future work. All right, and I think that is so just references and acknowledgements. Thank you to my mentor, Denny, and University of Pittsburgh. I did this paper over the summer through their training program. And that's it. That is my email, if anybody wants to email me. And so any questions?
Great. This is fantastic stuff. Really cool. And thanks for sharing all this with us. So I'll leave the chat open. I'll monitor the Q&A as well. And as people have any questions, please throw them in here. Yeah, so I was really interested in the the copy and paste, and just thinking in terms of like setting up expectations for the patient. It made me think of, I mean, none of this is funny, but the Seinfeld episode where Elaine gets deemed difficult in her chart. I don't know if you've ever seen this one, but so like, and then it just keeps going on and on. She can't get rid of this, and every provider that then sees her, makes like more, anything she does kind of fits that expectation that she's difficult. And so, yeah, I just wonder how that, influences the providers as well when they see something like that. And it's just like, oh yeah, they made this like tiny small comment, which I wouldn't have thought of otherwise, but now I'm just going to copy and paste that they're rude.
Yeah. I mean, that's also slightly unrelated, off topic, but if you ever read the book Dreamland, about the opioid crisis, basically the myth that opioids that are not addicting, it was a paper. It wasn't even a real paper. It was like somebody from Boston University wrote a letter to the editor or something saying like, oh, of the patients I've seen, none of them seem addicted to opioids. And then it just got like cited by so many people and just persisted for such a long time, and nobody ever questioned it. And then it just became fact in the medical community. Yeah.
No, it's totally related. Yeah, I can see that happening. Since we're talking about opioids, I was really thinking, like I mentioned, I do addictions and mental health work. I mean, I wonder, that might be another one that would be good to look at, in the context. So, mentioning opioids, is it in the context of like, hey, are you abusing opioids? Or, is it an offer of, you look like somebody that could really benefit from some prescription opioids?
Yeah. So that was the one area where we didn't try and do any further analysis, but Mimic has information on like what was given in the hospital that is much more standardized, not like free text stuff. So you could compare the counts from our analysis to what are the actual like recorded administered things, and if it's correlated, then you can say, okay, this is what's being administered in the hospital. Whereas if there's a gap, that's more suggestive of maybe it's something that they were struggling with previously. You could also plot it against the just national trends in addiction, or probably more appropriately, regional trends. If there's data just on Boston metropolitan area. And then the third thing to do would be just a little hand analysis. You could just start with a small random sample, and see if, just kind of get a sense of what's going on, and then expand that if you really feel compelled.
Sure. Yeah. No, that's really interesting. Okay. I was wondering, because our digital scholars are interested in these, tools that are out there. And I was wondering if you could tell us a little bit more about the LIWC program and the tool, and then maybe even like, you'd mentioned some ideas about how to improve it. I wonder if you could talk a little bit about that.
Yeah. Okay. So LIWC, very easy to use. And it's very cheap. So I don't know what the students are like, if they do their own projects or anything, but it was like $25 to use it, for the month that I was doing this analysis. And so I did have to like prep the note text. So I basically exported every single note into just a little TXT file, which I did in Python, and I had never used Python before, so it was doable. And then I basically, how did I do this? So you can go into LIWC, and it's like point and click. It is not for very tech savvy people, and I could just select the files that I wanted to input, and then it would just give you kind of this big chart with I think it gave you the word from that note, and then what category it fell into. Like it showed you like a flag if it fell into that category. That was using it just for kind of initial playing, but then there's another way to do it so that we could just do it for like a lot of notes at a time and then just immediately have that output exported to like Excel or CSV. I can say it was very intuitive if anybody is interested in using that. And it has a lot more categories than what we used. And it has, so it has like parts of speech. It has, I think they even had a category for like healthcare words. So, or maybe it was words related to illness. So maybe that was something that was underutilized by me, but they have all sorts of stuff. And what was the other thing I wanted to talk? What was the other thing besides the LIWC? Oh, how you might like create a healthcare tool like that. So, I mean, I don't know anything about, app or program development, but just conceptually, how would I go about that? I mean, it would require having an understanding of what words are commonly used in healthcare, and of those words, like what is commonly used in regular like lay language versus just in the clinical space. It would probably take a while and not just something that you could really do by yourself, at least the way I'm thinking about it. Because I think I mean, LIWC took a long time to develop, but really you would just need to create libraries of words and say these are in each of the categories, and then just apply it. I know people have like made modified versions of LIWC before, or at least that's what my mentor told me. So I don't have any additional details on how you might go about that, but I think other people have looked into this a little bit, maybe not for the purpose of recognizing bias in clinical notes, but for other purposes, because it is a very like general tool.
Gotcha. Okay, that's really helpful. Thank you. I mean, we can wrap up. I wanted to see if we're able to share the paper you talked about. The one I found is a preprint. Is that the one that's best to share?
My paper?
Yeah.
Yes, that's the preprint. Okay. We didn't submit it to any journal or anything, at least not yet.
I'm going to share that link because it looks like you can see the whole thing.
Yeah.
Cool. So if people are interested, please check that link out. And then also Karen posted a brief survey. If those are here, can take that survey, and we share that information with the speaker. And also there's some questions about future topics you might like to see here in the digital webinar. And on that note, we do have we usually take a break over the summer, but we have one more in June. And this one is, it's going to be a fun one. It's going to be a panel that we are hosting, talking with a bunch of people about their experiences building up their online presence. So we found some people that are really well followed on Twitter, but also who have established web pages and other social media accounts, because we know a lot of our scholars are interested in trying to develop up that online presence, as a way to share your work, but also, to connect with professional colleagues as well. So please look for that. That's going to be on June 1st, and we'll send announcements related to that. So I think that's it. I want to thank Jacqueline so much for coming and sharing this great research project with us. And we look forward to seeing some of your future work, and wish you the best of luck in medical school.
Thank you. Thanks for having me.